Good evening, all. So, once again, welcome to the FNCC fortnightly classes. This class is being done by Anshul, and the topic for we are starting the series on stroke, and the first one is the most important one: management of ischemic stroke, both thrombolysis and thrombectomy. Please keep it as live as you can, ask as many questions as you can, clarify your doubts, because this is our bread and butter. Everyone has dealt with it, everyone has their own um, bundle of problems. This is the place to clarify it. So, Anshul, shall we start?
Yes, ma'am. Sharing house disabled. Start करें, ma'am?
Yeah, you may start at 7.
Good evening. So I'll be talking about an ischemic stroke which came to our hospital recently in last 10-15 days back. So she was a 60-year-old female presented with acute onset of generalized body pain and left side weakness at home around 3 a.m. on 19th of October 2025. She came to emergency department at around 4:15 a.m. So past medical history was she has no history of any similar symptoms in the past. Known case of diabetes and hypertension since 15 years on linagliptin 5 mg OD. She is a known case of coronary artery disease with ejection fraction of 25% post PTCA 10 years back on tablet Ecosprin 75 mg, Avast 20 mg, Bisoprolol 5 mg, and Ditot 10 mg. So on presentation emergency, on examination, patient is around 60 kgs. GCS was E3 V5 M6. Blood pressure was 170 by 90 mm of Hg. Pulse rate was 80 per minute. Respiratory was 18. Temperature was afebrile. Saturation was 98% on room air. Patient was conscious, oriented, responding to verbal commands but with a slurred speech. She had patent airway, bilateral lung clear, regular cardiac rhythm with no abnormal sounds. Pupils were bilaterally reacting and equal in size. There was facial weakness, loss of left nasolabial fold flattening, and deviation of mouth and swallowing was impaired. Left upper limb power was 0 by 5, lower limb was 3 by 5, right upper limb and right lower limb was 5 by 5 power, and deep tendon reflexes was 2 positive. NIHS score was calculated and it was 12. Blood investigation was sent and urgent CT was done. So the neuroimaging showed dense MCA sign. You can see a dense MCA sign on the right side. IV thrombolysis was planned. So patient was thrombolized at 4:45 a.m. with altiplase of 0.9 mg per kg.
Anshul,
A dose.
just one question. Before you decided to do IV thrombolysis, other than CT, what other investigation did you do?
So, ma'am, bedside in emergency, first we should rule out stroke mimics. First is hypoglycemia is done. Hypoglycemia is ruled out on the bedside only.
Go on.
And other investigations like complete blood count to look for any thrombocytopenia. If there is any past history of thrombocytopenia, we can rule out that or no. And coagulation profile like INR, APTT, renal function test.
So, in nutshell, what are the absolute contraindications for IV thrombolysis?
In nutshell, ma'am, if there is thrombocytopenia less than 1 lakh or INR of more than 1.7.
Are they absolute contraindication? Anyone in the group can answer, please. All of you are equally involved in this discussion. Please be forthcoming.
So, Dr. Anshul, the absolute contraindications are like any history of ICH, previous history of ICH, or patient has major surgery within 14 days, or he's having aortic arch dissection, infective endocarditis. Then we have to take a very important history of like patient on anticoagulant, if he's on anticoagulant or not. Because if patient has taken like NOACs in last 48 hours,
In
then
last 48 hours. Yes, yes.
and regarding heparin, or if he has taken therapeutic dose of heparin in last 24 hours. And regarding vitamin K antagonist, we have to check the INR, because if patient is on vitamin K antagonist and his INR is more than 1.7, then it's a contraindication. But most of the time, like if patient, like initially MI was taken as MI within 3 months was taken as an absolute contraindication. But now some guidelines are saying that if patient is having non-STEMI, then along with the consultation of cardiologist, we may go for thrombolysis.
Exactly. So most of the situation is historically you take history and find out what are the possible contraindications. If there is, then only you do these blood investigations to prove the thrombocytopenia, INR high and all. And most of the cases are relative contraindication. The idea is to save as much brain as possible and do thrombolysis for as many as possible. That's what we are trying to arrive at. Go on, please.
So patient sensorium and vitals remain stable post thrombolysis. Patient was shifted to the neuro ICU for further care.
So, Dr. Anshul, what are your blood pressure targets? Like you have decided for thrombolysis of this patient. So, what were your targets during the thrombolysis and before
Uh,
starting thrombolysis and during thrombolysis?
Before thrombolysis, if blood pressure is more than 185 by 110 mm of Hg, so we should lower it to less than 185 by 105 mm of Hg.
Okay. And you chose LT place. So, while giving LT place, what monitoring will you do while giving the infusion?
First is to look for any reactions like anaphylaxis or and GCS monitoring and vital monitoring are done.
So yes, we have to do GCS monitoring. We have to look for any complication, and then we have should also monitor blood pressure. And it has
Blood
to be
pressure.
done more frequently compared to other cases. So it should be monitored every 15 minutes for first 2 hours, and then every 30 minutes for 6 hours, and then every 1 hour for 16 hours. So along with GCS, any complication, and we should also monitor regularly the vitals of the patient.
So,
Yes,
Anshul, in your hospital, where does the patient get lysed? In the ED or in the ICU?
in the emergency one.
Yeah, so most of the time we will not come across it. But once the patient has, you said this time it was TPA. So, what is the safe time period to put an outline in case of patient lies with TPA versus uh, tenecteplase?
It should be placed before giving any APA.
So, what is the advantage of tenecteplase compared to TPA?
In tenecteplase is given as a IV bolus only, and in this RTPA alteplase is given over 1 hour. So if
How
a
does it
patient has
matter? How does
if a
it matter
patient
for us?
if a patient has a large vessel stroke and mm, we want to go for a mechanical thrombectomy, so the puncture to groin time is more for RTPA.
Excellent, excellent. That's the advantage with the advent of all these thrombectomy procedures. The time loss is much shorter with thrombolysis. And as far as the ICU itself is concerned, everything now hovers around BP. In the ABC, the circulation management makes a big difference in the final outcome within the ICU. So if you give tenecteplase, we are able to put in a line earlier, manage the BP better, so that makes a huge difference. Go on, please.
So thrombolysis, this IV RTPA treatment was shown to benefit in patient with acute ischemic stroke in 1995 NINDS trial. IV-RTPA was a major milestone in stroke treatment as a first disease-modifying therapy for acute ischemic stroke. In 1996, FDA approved the use of IV-RTPA for a patient with acute ischemic stroke presented within 3 hours of the symptom onset. In 2008, ICAS 3 trial, this was European study, showed benefit of IV-RTPA over placebo among those treated within 3 to 4.5 hours also. In 2015, stroke guidelines was modified from the American Heart Association recommended using it up to 4.5 hours from the onset of symptoms in eligible patients. So issues with IV thrombolysis is intravenous recombinant tissue plasminogen activator is an approved therapy for patient with AIS presented within 0 to 4.5 hours. 50% of the patient receiving IV RTPA was still either severely disabled or dead. The absolute reduction in chance of poor outcome in patient treated with IV RTPA within 3 hours is 10%. In 3 to 4.5 hours, the effect is further reduced to 7%. There is inadequately complete recanalization, nearly 13 to 50%, and there is chances of hemorrhagic transformation also.
Yeah, so if you were to summarize what you presented in this slide, as the time progresses to lysis, the number needed to treat increases, and at the same time, it is at a expense of greater complications.
Disability.
So both go hand in hand. That is why the sooner you can, the better it is. Also, one point, Anshul, we reached therapeutic measures much earlier. What about CT scan versus MRI scans? Which would you prefer?
Ma'am, city is faster and it is available in every center. So city is done primarily and uh, MRI takes time and the time is brain. So
If you have a possibility to get only limited these things, limited views of MRI, limited sequences, and your time factor is taken care of, in that case, which would you prefer and why? CT versus MRI.
MRI is preferred in because starting period के अंदर in city it is difficult to pick up the stroke मतलब ischemia. Uh,
Why are you doing the CT first of all? Is it to look for the stroke or what else is
just
it?
to rule out any hemorrhage.
Correct. So that serves your purpose for CT. But what is the advantage of MRI?
Mm,
And which sequence will you prefer? Like first sequence in MRI, which sequence will you order for MRI if you want to detect the early stroke?
diffusion weighted MRI, diffusion weighted images.
Why? It gives you a fair diffusion flare mismatch, will give you a fair idea of the core versus penumbra. And all the guidelines, the way forward is if you have a penumbra, save it. All the guidelines are going towards that. So smaller core, larger penumbra, even beyond the time frame, you may go ahead and do a
With the
corrective
thrombolysis.
lyse or thrombectomy, whatever. So it is important that if you can manage without losing time to get a few sequences to find out this mismatch, MRI would be a good idea. Next thing, in CT, if you're doing CT, when will you not take for license? One, you said hemorrhage. What are you actually doing with CT? Any scores that you're looking for? How does that go?
Aspect score is done, ma'am.
Correct. How does that move? How does that help you in decision making? What is the total score? How do you
Total score
decide?
is 10.
Correct.
The lesser the score, more is the disability.
Yeah. So the more the each area involved, you minus one for each territory, and then if it is less than, how much is the cutoff?
6.
6. If it is less than 6, the core is bigger. And initial studies were saying it is futile to probably lyse. But things are being questioned more and more, and bigger cores are also being lysed. Yeah, please go ahead. This aspect we had left back.
Dr.
Sorry
Anshul,
for interrupting.
we talked about the radiology, but you also talked about NIHS score. So, what is the importance of calculating NIHS score when patient presents in the emergency? How does it help us in guiding the treatment?
सर आपकी इस्कीमिया का ग्रेडिंग के लिए आता है सर, माइल्ड मॉडरेट और सीवियर के लिए.
Right.
If it is less than 5, so it is a mild stroke
And more
to
than 25 is severe stroke.
severe stroke.
So the thing is, NIHSS can be performed rapidly. It has like 42 points. We can perform it. It quantifies a degree of deficit because if you want to talk to neurologist, like what is the severity of stroke, so you can talk to communicate with your neurologist. So it helps in facilitating communication. Then it also identifies the patient for fibrinolytic therapy or mechanical therapy, like what therapy you have to go. And you can also allow the objective measurement of changes. Up suppose minor stroke, and then will you thrombolyze the patient? If patient is having say score of 0 to 5, then you will thrombolyze the patient or not?
सर मैम अगर वो डिसेबलिंग स्ट्रोक है तो आपको थ्रोम्बोलाइज करना पड़ेगा.
Yes. So disabling stroke regardless of NIH score, patient
NIHS.
will be thrombolyzed. Yes, good.
And when will you not thrombolyze?
If it's
You said 0 to
a
5. One more criteria based on NIHSS. When will you not lyse? If it is rapidly recovering.
rapidly recovering stroke.
Carry on, please.
So contraindication of IV RTPA is onset of symptoms more than 4.5 hours, significant head trauma or prior stroke in previous 3 months, any history of previous intracranial hemorrhage, acute bleeding diastasis, including platelet count of less than 1 lakh, INR of more than 1.7, arterial puncture at non-compressible site in previous 7 days, recent major surgery within 14 days or recent GI tract hemorrhage within 21 days, current use of direct thrombin inhibitors or direct factor 10A inhibitors, history of previous intracranial neoplasm, AV malformation, or aneurysm, CT showing early ischemic signs in more than one third of the MCA artery distribution. So during the hospital course, 8 hours post thrombolysis, patient has fallen GCS to E2 V2 M5. Bilateral pupils were 2 mm in size and reacting to light. Urgent CT was done in view of deterioration in the GCS. So post thrombolysis, there was bleed. CTs showed multiple areas of intraparenchymal hemorrhage with surrounding edema in right frontoparietal region with midline shift of 3.1 mm.
Sorry to interrupt. Before we move on to this, so when you are lysing the patient after lysis, what is the in what terms do we say that lysis was successful? What scoring do you do? When will you say that yes, the patient is recovering, has done well? Anybody? Other students? What is TC scoring? So you look for the filling of the obstructed vessels. Many a time, since you brought up this scan, many a times post lysis you might see all the occluded vessels filling up, having a good flow. TC3, 2B3, 3AB, everything is supposed to be good flow. Does the good flow translate to good clinical outcome? So after the patient comes out of the radiology suite and radiologist tells you it's a beautiful filling, all the block has been taken care of, you are going to face the music facing the relatives. What are you going to say? Are you categorically going to tell them everything is done, you are good now? How will you go about it? Anybody can answer, please. This is daily affair. So the answer is no, you cannot. Perfusion Restoration of perfusion versus clinical improvement are not the same thing. So
तिन्ही
hours,
पिशवी दुसरा एक डब्बा आहे ना ज्याच्यात
hours after you have done you've seen after lysis that the perfusion is good, this hemorrhagic transformation can occur and patient might deteriorate. So you cannot be judgmental just based on the angio images. Please keep that in mind. Okay, continue.
Management of post-thrombolysis bleed is patient was administered injection tranexamic acid and transfused cryoprecipitates. Anti-edema measures were initiated and neurosurgical consultation was done and patient was under close monitoring.
Dr. Anshul, what is the incidence of this post thrombolysis bleed?
Around 10 to 15% of the patients.
It's around 6%, I think that various studies have shown, but it may vary depending upon the risk factors for the patient. So what could be the risk factors for bleed in this patient, do you think?
Old age.
Okay.
Uh,
Was blood pressure controlled in this patient? Because high blood pressure post thrombolysis is also one of the important risk factor.
yeah, so blood pressure was maintained.
So this patient was also diabetic. So diabetes, some studies have shown that in diabetics patient, there may be some small increase of high risk of bleeding. Okay.
So what is the ideal BP to be maintained after lysis?
Less than 185 by 105.
Are you dogmatic about it? It's rather a 15% drop from what he presented with. Now, suppose that drop happens to be less than 180, say 160, or say 120 it has come down to. Are you going to start NORAD to improve his BP?
No, ma'am.
It is individual. It depends upon the patient's clinical situation.
Mhm.
And you shouldn't be, basically, the drop should only be 15%, and the peaks and valleys should not be allowed to happen. You cannot bring up the BP too much and then let it fall. You have to maintain a constant level. Now, what is the beautiful constant for each patient is different. In fact, there has been a study in which they have given phenylephrine boluses and maintained the BP so as to clinically bring about 2 NIHS score improvement. That is a very diligent work to do, but they have done, and that did not bring about a functional improvement. And this is one of study. Does that translate that there is no individual map target? We do not know. But as much as possible, the variation in BP should be avoided. What Puneet said was correct. BP could be one of the factors why the hemorrhagic transformation happened in the first place. Please carry on.
So, Dr. Anshul, you gave this cryoprecipitate and tranexamic acid to manage the post-thrombolysis bleed. So, why did you prefer these two agents? What does cryoprecipitate contain?
Sir?
What factors does cryoprecipitate contain? So basically, we are giving fibrinolytic agent. We are giving fibrinolytic agent, so we have to replace fibrinogen. So cryoprecipitate basically contains factor 2, which is fibrinogen, factor 8, von Willebrand, and factor 30. So even though there is no gold standard that what coagulation factor should be replaced, but because based on the mechanism of action of fibrinolytic agents, we prefer this tranexamic acid and cryoprecipitate because cryoprecipitate is rich in fibrinogen.
ஒரு stroke class.
Okay.
Yes, sir.
Carry on.
So CT had post thrombolysis was done after 48 hours. It shows no further increase in the bleed. During the hospital course, patient has improvement in GCS over next few days. Anti-edema drugs were continued in view of cerebral edema. Tablet ecosprin 75 was started after consultation with the neurologist after 48 hours. Echo showed global hypokinesia,
இப்பதான் டியூட்டி
elevation
சொன்னேன்
diastolic
மாத்தி
dysfunction of grade 3. no clot and vegetation,
Confirm, sir.
ejection fraction of around 30%. Enteral nutrition was initiated and blood glucose monitoring was done.
Hmm.
So this was carotid Doppler. This revealed extensive atherosclerotic changes.
மாத்திட்டேன்.
Just one second,
Medication.
Anshul. Just 1 second. Dr. Vasanti, your mic is on. We cannot listen beyond your voice. Dr. Vasanti, please mute your Thank you. Carry on.
Antiplatelet diuretics and subcutaneous insulin and enteral nutrition was continued. Patient was shifted to the ward 5 days post thrombolysis. At the time of shifting, patient was conscious on room air requiring urinary catheter. Patient returned to the ICU 5 days later with fever and drowsiness. Repeat MRI was done. There was raised TLC. Urine culture showed E. coli. So this was the MRI. The study shows diffusion restricted with hemorrhagic signal intensity within the right frontotemporal cortical region and left corona radiata. So patient UTI was managed with IV antibiotics and patient has improvement in GCS. She started accepting orally. Patient was discharged home after 18 days of the hospital stay.
Just to complete the discussion, Anshul, when would you have considered thrombectomy after thrombolysis? In what scenario?
If there is intracranial ICA stroke or M1 territory of the MCA or vertebral or basilar.
How is that described? Large artery occlusion.
Large vessel occlusion. Large vessel occlusion.
So, is there a time frame for thrombectomy?
Within 6 hours, it is done.
Everything is being pushed now. So, it all depends. If you have a perfusion imaging possible, if nothing at all, an MRI flare DWM mismatch is enough. If you have a perfusion scan, even better. If you have a mismatch, you're suggesting that penumbra is big, irrespective of the time you can go ahead with a thrombectomy if large artery occlusion is seen. Continue, please.
So case 2 is IV thrombectomy for IV thrombolysis followed by mechanical thrombectomy. 20-year-old man with no past medical history presented to a primary stroke center with sudden left side weakness and imbalance followed by decreased level of consciousness. HCT showed no hemorrhage, no acute ischemic changes, and a hyperdense basilar artery. CT angiography showed mid-basilar occlusion. So CT had showed no hemorrhage, no acute ischemic changes, and a hyperdense basilar artery. CT angiography showed mid-basilar occlusion in this area. So he received altiplase IV TPA and was transferred to the comprehensive stroke center where angiography confirmed mid-basilar occlusion and he underwent mechanical thrombectomy with recanalization of the basilar artery. His neurological examination improved and he was discharged to home after 2 days. At his 3-month follow-up, he was back to normal and returned to the college.
Just a second. In the chat, Dr. Gaurav has asked, what is your idea about arterial line and catheterizing the patient just before the thrombectomy?
For the thrombectomy.
Hmm.
So for 24 hours, there should be no invasive procedure to be performed.
Irrespective of what you've given for lysis?
For altiplase.
Yeah. In your case, it was altiplase, but if it is tenecteplase, you may.
You can perform.
Another question is, when we were lysing the patient, there were more and more studies saying that probably we may not need anesthetic help and we might end up saving time if not without any anesthesia help, you went ahead and lysed. But now the thrombectomy is come into the scene. what is your take on the role of anesthesia? Presence of anesthetist in the suit while thrombectomy is done, does it make a difference?
Ma'am, for airway, ideally we should have.
For multiple reasons, it has been shown that there was a JAMA article recently, I think around 2 weeks back, which said the presence of anesthetist makes a difference. There's improvement in functional outcome. Multiple reasons. Airway is one thing. And when the radiologist is busy doing the procedure, blood pressure is not very well monitored. And when there is an anesthetist around, that is also taken care of. All these small nitty-gritty things, they make a big functional outcome difference. So yes, anesthetists are welcome in the stroke management now. Carry on, please.
So selecting patient for mechanical thrombectomy should not be delayed to assess the response of the IV TPA. Inclusion criteria is a clinical diagnosis of acute stroke with deficit of NIH score of more than 2 points, an aspect of more than or equal to 6 on non-contrast brain CT and MRI scan ruling out intracranial hemorrhage, intracranial arterial occlusion of distal intracranial ICA or a middle or anterior cerebral artery demonstrated on CT angio or MR angio or digital subtraction angiography. Sufficient time to initiate endovascular thrombectomy within 6 hours of the stroke onset, and informed consent and age should be more than or equal to 18 years.
So, Dr. Anshul, two questions from me. One is that why do we need mechanical thrombectomy if we have already thrombolized the patient? Like patient came within 2 hours, we thrombolized the patient. So why do you think that there may be a need for mechanical thrombectomy in that patient?
Studies have shown that in addition to the IV thrombolysis, if it is a large vessel stroke, then mechanical thrombectomy improves the functional outcome of the patient.
Right, because IV thrombolysis can sometimes is not able to canalize the artery. It is not able to restore the flow. So we may need mechanical thrombectomy in those patients. So another question is that if suppose patient is eligible for both thrombolysis and mechanical thrombectomy, so how will you proceed in that patient?
So starting में IV thrombolysis should be done. It is seen bridging thrombectomy is better for a functional outcome.
So if patient is eligible for both, then yes, IV thrombolysis should be done,
Both
followed by
should be
mechanical
done.
thrombectomy. But we should not delay the mechanical thrombectomy and vice versa. We should also not delay the IV thrombolysis.
Anshul, taking that discussion further, you've done lysis, you've gone to thrombectomy, and still you've not been able to take out the full thrombus. Is there a role for one more lysis? All this is happening for heart. Why not for brain? The answer is it is in the pipeline. There are studies ongoing. I think 1 or 2 results, I think from China have come, but larger guideline level recommendation has not come. This is a thing to look up for in the future. There might be some kind of a consensus on it. Carry on.
Sorry, can I come in here with the permission of the chair?
Please, please, please.
So, well done, Anshul. So the word to say in the exam is bridging thrombolysis and thrombectomy. What the best evidence for mechanical thrombectomy is that once you have an eligible major vessel, you do the thrombolysis if it's in the window. Most of the time, it will not be in the window for thrombolysis. So empty windows are very big and empty you proceed. But if you are thrombolizing, you do not wait for the result. That's why the word is bridging thrombolysis, and you take the patient to the DSA lab. That's what the best stroke centers would be doing. And the assessment carries on the DSA, the intervention lab table itself. It doesn't harm if the patient is improved, you can bail out there as well. So the aim is that you do the thrombectomy as quickly as possible. If you've given the thrombolysis, it's an eligible major vessel, you don't wait for the response in the resuscitation room, waiting for it to happen. You go straight away to the lab and you assess the response there. If the response has not happened, you go in for a thrombectomy. So the best evidence is for bridging thrombolysis and thrombectomy done together. And if I were to just go back to the previous question that I put on the group, nothing is absolute in medicine. So yes, you definitely do not need arterial lines for, as you said, for strokes. You just need good blood pressures to be maintained. On the catheter note, I would put a catheter for every thrombectomy happening. And I'll ask you the reason. You will tell me the reason after you've finished and think about it, and we can discuss about that. It's not that invasive procedures are not allowed. A urinary catheter is, in my books, a must. Sorry, please proceed.
Exclusion criteria is arterial blood pressure of more than 185 by 110 mm of Hg, and blood glucose should not be less than 50. Intravenous treatment with thrombolytic therapy in dose of exceeding 0.9 mg per kg, or laboratory evidence of coagulation abnormalities, example like platelet of less than 40,000 or INR of more than 3. So mechanical thrombectomy devices, there are two generations, first generation and second generation. First is Mercy Retriever and Penumbra system devices. Second is solitary flow restoration device and Trevo retrievers. Mercy is mechanical embolus removal in cerebral ischemia device. The device is made up of corkscrew shaped nitinol wire that is deployed into the thrombus in the occluded intracranial artery. So this is what device look like. Stent retrievers are designed for the purpose of stent-assisted coiling and for retracting the errant coils dislodged during the endovascular procedure, effective in capturing the naturally occurring thrombus and could affect early vessel recanalization. Self-expanding stents that are delivered across the thrombus with the help of the microcatheter. Their design with multiple crisscrossing strands ensure the capture of the thrombus within the stent wall, followed by the withdrawal of the unfaulted strength into the guide wire and under constant aspiration. So in investigational method, intraarterial thrombolysis, the dose of the thrombolytic drug can be limited to the needed of the for recanalization since the procedure is done under direct visualization. The total dose of intraarterial therapy is about one-third of the IV dose. Intraarterial thrombolysis is reasonable treatment option for the patient with acute ischemic stroke who have contraindication to the IV thrombolysis. There was PROACT 2 trial. Patient receiving intraarterial recombinant pro-urokinase were more likely to have recanalization 66 versus 18% and to achieve functional independence at 90 days 40 versus 25%. This group has a significant higher incidence of the symptomatic intracranial hemorrhage within 24 hours. There is also ultrasound enhanced thrombolysis. Ultrasound energy may have a biological effect that facilitate the activity of the fibrinolytic activity. This is employed to enhance the thrombolysis in the patient with acute stroke treated with the intravenous TPA. Clotburst trial, the rate of sustained complete recanalization at 2 hours was significantly increased for the treatment group compared to the placebo group, 38 versus 13%. Ultrasound enhanced thrombolysis hold promises for improving the recanalization rate and outcomes in the acute ischemic stroke. This technique is investigational and there is a risk of symptomatic hemorrhage, particularly with low frequency ultrasound. Combined intravenous and intraarterial thrombolysis. The rationale for combined intravenous and intraarterial thrombolytic therapy is to unite the advantage of each, wide availability of the early rapid IV thrombolysis, potentially higher recanalization rate, and therefore better outcome. EMS3 trial found that the combined approach yielded no additional benefit compared to the IV thrombolysis alone. So current recommendation are due to the consistent finding across multi-endovascular trials in the recent revision of the guidelines of the AHA. The class 1 recommendation was made for the use of mechanical thrombectomy along with the IV RTPA in treatment for acute ischemic stroke for eligible patients. And the guidelines endorse the use of the IV RTP in combination with the mechanical thrombectomy in patients with the acute ischemic stroke of less than 6 hours duration who have large vessel occlusion confirmed with the vascular imaging. The evidence of mechanical thrombectomy is less clear for the patient presenting more than 6 hours after the symptom onset. The evidence for mechanical thrombectomy is also not clear for the patient with posterior circulation stroke, as the majority of present and past trials have excluded these patients. The guidelines also recommend the use of stent retrievers as the first line device. Recommendation include faster door to recanalization time, the angiographic tool of TC2B3 for better outcome. So conclusion is recent endovascular acute stroke trials have compelling demonstrated the superiority of combined treatment with mechanical thrombectomy and IV RDPA over medical therapy alone for patients with large vessel stroke who present within 6 hours. There is revolutionary advance in our ability to combat the massive disability that result from the stroke. Perfusion imaging and technical advantages in mechanical thrombectomy expand the number of candidates for meaningful endovascular intervention.
That was a very
Thank you.
open presentation. You touched upon almost everything. Two aspects we haven't discussed. Tomorrow, a very daily activity, non-dependent 80-year-old presents to you with AIS. Are you going to lyse him or not?
Non-dependent.
Hmm?
एक बार repeat करें.
80-year-old.
Okay.
Comorbidities are there, but he has a good life. He's managing his daily activities by himself without any support, and has now had a stroke and has presented to you. Is
Yes,
age
ma'am,
a
we should
criteria?
thrombolize. It is disabling stroke, ma'am.
Correct. So age, is it a criteria? Again, the whole house is open for you. Anyone can answer, please.
Age is not a criteria, ma'am.
Yeah, age is not a criteria, but most of the studies have kept the inclusion criteria up to 80 years. Beyond 80 years, nobody has taken. 80 is usually the highest limit to which they have taken. That also in the recent times. One more aspect of stroke management not touched was wake up stroke. How will you manage wake up strokes?
Wake up stroke के अंदर आप डिफ्यूजन वेटेड और फ्लेयर मिसमैच करके देख सकते हैं.
Yeah, so what is the criteria? You're right. Elaborate on it.
Wake up stroke is a
So, Dr. Anshul, in wake up stroke, there should be like abnormal signal on diffusion weighted image, but there should be no visible change on flare. So that is diffusion flare mismatch. Then the diffusion changes should not be more than 1/3 of MCA territory. Okay. And as per the trial, NIHS score should be 25 or less. That is, it should not be a severe stroke. And then patient should not be planned for thrombectomy. So if patient is in a center, like in our center where thrombectomy is not done, then we can consider the patient for IV thrombolysis. So these are the criteria for wake-up stroke.
Dr. Urvi had a question. Dr. Urvi, please go ahead.
Yeah, so I think there are a couple of studies on role of tirofiban for patients who are not eligible for mechanical thrombectomy post acute ischemic stroke. And so I think, if I remember correctly, the selection of these patients are again not eligible for mechanical thrombectomy. So basically, not a large vessel occlusion stroke. Secondly, they could or could not have been thrombolized using whatever drug considered by the clinician. Thirdly, patients who do not improve post thrombolysis. The fourth, if they improve but they deteriorate within 24 hours of improving, and I think criteria for improvement is the same. NIH score should increase by 2 points post thrombolysis. So I think these are the few criteria for the studies that have been published for use of tirofiban in acute ischemic stroke.
Thanks, Urvi.
So Dr. Anshul, one aspect we discussed that mechanical thrombectomy can be done within 6 hours, है ना? In patients who have large vessel occlusion. So can we do it like in the window, like in the period of 6 to 24 hours following the stroke symptoms? Is there any evidence that mechanical thrombectomy may be beneficial in such group of patients beyond 6 hours also?
Beyond 6 hours, सर कुछ स्टडीज हुई हैं, बट फॉर फंक्शनल आउटकम के अंदर
So recently, two RCTs have been done for mechanical thrombectomy beyond 6 hours. That is the Dawn trial and the Diffuse 3 trials.
Diffuse 3
have included patients beyond 6 hours, and now studies. But before going for mechanical thrombectomy in such patients, we have to meet the criteria which they have used. That is of large the core penumbra core ratio and other things. We have to fulfill the criteria of these two trials before proceeding for mechanical thrombectomy. Okay.
All the fellows, do you remember anything we did in journal club with respect to mechanical thrombectomy patients? One of the articles we looked up at. Can anyone tell about neuromonitoring? So Anshul, what is the role of quantitative pupillometry in thrombectomy patients we just did recently? That article we did, it had shown that in the quantitative pupillometry, other than the QPI index, the NPI index, neurological pupillary index that all of us know about, the pupillometer also gives many other parameters like latency, construction velocity, dilatation velocity. And the study that Ankur had chosen, it had shown dilatation velocity was even more sensitive to the tune of 10 hours before clinical deterioration. That is huge. And when NPI index and dilatation velocity were combined, the p-value had improved to the tune of 0.004, massive improvement. So post thrombectomy, the circulatory changes that happen compared to lysis alone are very different. That has to be kept in mind when you're monitoring these patients. Anybody has any more questions? If not, I would like to thank you, both the presenter and the...
Just a couple of things, Shalini. Sorry, I am driving.
Please. Go ahead.
To ask the speaker, what is the difference between an anterior and posterior stroke if they're going for thrombectomies? What precautions you need to keep in mind as an intensivist or as an anesthetist?
posterior stroke, there are chances of the space there is very less, तो ICP raise के chances बहुत ज़्यादा हो जाते हैं.
So space se pehle, where the area is being supplied, you have to understand it's a stroke is a dynamic process happening in front of you. So in anterior circulation, you're only going to get weaknesses. But in posterior circulation, if a vertebral becomes a basilar becomes a brainstem, what is going to get compromised if the patient was awake with maybe a decent
Airway will be compromised.
Airway and respiration will get compromised in front of you. So what you have to understand, it is a very dynamic process. As they are moving all their hardware and software inside the vessels, it can become dislodged as well, what was happening in the first generation trials with the Mercy devices and all. So you got to be prepared to deal with your airway, all the more so in posterior circulation strokes. That is why sedations are almost a no-go for posterior circulation strokes. And there is a very, very low threshold to control the airway if you have any doubt about a posterior circulation stroke going onto the table. There have been lives lost in the earlier trials of posterior circulation strokes where sedation GAs were being blamed and the anesthetists were being blamed. So we be very careful about posterior circulation strokes going for empty, and be very, very cautious for having sedations. GAs are not a problem, provided you just give a simple GA but keep the blood pressure high. Problem is not with the anesthetic. Problem is how you do it. Number two, I asked the question before, what about the urinary catheter? A very small issue, you might say, an annoying issue in the whole thing. What's your opinion about catheterization of patients who have acute stroke and going for thrombolysis or thrombectomy after that?
Catheter should be placed before this mechanical thrombectomy.
Okay, if you are going for thrombectomy, why? Why is the question? Thrombolysis may most of the neurologists might not agree, and they'll say not required, thrombolize, no invasive things for 24 hours, so on and so forth. But what about thrombectomy and urinary catheter? So what gets given during a thrombectomy is at least on an average 2 liters of fluid, not by you as an intensivist or anesthetist, but by the radiologist. The average is between 1.75 to 2.25 liters of fluid that gets pumped into the patient. If it is a difficult thrombectomy, a bit more fluid will go in all their pressurized bags. And in those bags is nimodipine, which they will not tell you. So you will doubly struggle to maintain your blood pressure. But all that fluid is going there. All that fluid is cold. That fluid is not warm. And those patients, especially if their NHS score is high or they are especially elderly, they get incontinent, they get extremely hypothermic, and you might have a good Tiki score and a revascularization, but they'll be shivering either in your ICU or post-op units. So that compromises your brain physiology much to the detriment of everything else. So that is why a good, well-practiced stroke pathway will have enough time for a catheter to sneak in. And that is probably as good as a cannula, as much as a cannula is required. Lines are not required, but a catheter is as much as a must. And I speak that because of we've seen all ends and fought all ends for this catheter. So that's why you fight for it. Thank you. That's all from my end. Sorry, I've dragged it.
Thanks, Gaurav. That was a good insight. Sanchi, your answer is perfect. So you again, depending on the MRI, how much pons is involved, you cannot tell this patient. I mean, medulla is involved. You cannot say is this patient going to arrest, is his respiration is going to be preserved or not. That's a very difficult call to make. But like what Gaurav said, if you have a posterior circulation arrest, posterior circulation stroke, you have to be very, very diligent. You can't wait for the nurse to call up that there is anazochoria, there is bradycardia, Cushing reflex. There might suddenly be an arrest. So usually when you're leaving at the end of the day, by evening, the person who's on call has to be doubly alerted. This can happen. Somebody has to keep a watch on it. Anything we have missed, Puneet?
No, ma'am, we have covered most of the things. Uh, One thing I will just like to ask is like if patient is on dual antiplatelets, then will you thrombolize the patient because a patient has recent PTCA and is on dual antiplatelets? Then what is your
Oh, that takes you to another level. This was one of the topics given to me for the national conference, our SNCC national conference this year. So,
okay?
one person who is on maximum medical management of stroke and stroke recurs, what do you do?
Okay.
Lysis will not work. Thrombectomy will be very difficult because already very friable vessels under the treatment of dual antiplatelets, the chances of vessel wall injury is very, very high. What literature says is you should take up advanced imaging techniques, perfusion scans, even TCD is helpful to see how much of collateral is involved. And the way to go forward is surgical involvement. STMCA bypasses are the way to go if this is a recurrent stroke on maximum medical management. How
Okay.
far it works in our country as of now, I am not very sure. In our center, we are just about starting STMCA bypasses for stroke. Till now, we haven't. In a month or so, we will be starting.
Thank you. Thank you.
True, Sanchi, again, increased risk of hemorrhage if you're giving DAPT and you have this problem. I think with that, I'm sure there are many small aspects of ischemic stroke management we haven't fulfilled. Everybody will have to do their backup reading, but otherwise, we have done very good job of touching almost everything. Thank you, Anshul. Thank you, Puneet, for all your efforts. It was a wonderful
Thank you.
presentation. And Anshul, you touched on the literature very well. I hope all your effort bears fruit for your practical bedside achievements also. Thank you very much. Good night until we see you again a fortnight later. Good night.
Thank you.